Welcome, everyone. Welcome. Good morning, good afternoon, good evening. I'm seeing guests joining us from really all around the world. This is such an exciting time for us to be coming together, specifically around gender equity and gender-based violence. Welcome, welcome, welcome. Well, I'm going to go ahead and kick us off. We are just at the top of the hour, and we've got an incredible agenda lined up for today. I want to take a moment to welcome everyone that is joining us from different time zones and really all around the world. I'm Michelle Decker. As many of you know, I am a professor here at the Johns Hopkins School of Public Health, and I have the pleasure of being the director of our Johns Hopkins Center for Global Women's Health and Gender Equity. And our agenda for today is featuring our scholars and our trainees through our Evidence Accelerators program. This is our flagship initiative, and it is really the first year that we've been able to offer this training. And so we're absolutely thrilled to be able to showcase our scholars and our trainees through a series of webinars. This is the first that we'll be kicking off. And this was a competitive application process, and we were able to identify and bring in 12 amazing scholars and evidence accelerators, bringing the work together around gender equity and gender-based violence, going through our mentored program throughout the year and taking our virtual coursework. And I'm just so delighted to have an opportunity to introduce our guests today. And I'm actually going to turn us right over to Dr. Rosemary Morgan with the center, who is going to be our moderator for this morning. And I welcome everyone to really enjoy and engage in the conversation and the dialogue, and looking forward to a wonderful opportunity. Rosemary, over to you, Dr. Morgan. Thank you.
Thank you, Dr. Decker, and I'm delighted to be here with all of you today to be the moderator for today's webinar. And welcome, good morning, good afternoon, good evening to all of you for wherever you're joining us. It is my absolute pleasure to introduce our first speaker, Dr. Omera Nasser. So Dr. Omera Nasser is the team lead and senior scientist of the National AMR, that's Antimicrobial Resistance Program at the National Institutes for Health in Pakistan. The title of our presentation today is Gender Dynamics and Behavioral and Social Drivers of Child Vaccination in Urban Slums of Pakistan. So over to Dr. Nasser.
The title of my project is Gender Dynamics and Behavioral and Social Drivers of Child Vaccination in Urban Slums of Pakistan. Research question is, among mothers in urban slums of Pakistan, how do behavioral and social drivers of childhood vaccination associate with vaccination uptake? Does this association differ by child's gender? Why this matters and why we have taken up this topic? Because the majority of zero-dose children are concentrated in lower middle income countries. In 2020, 16.6 million out of around 17 million zero-dose children globally resided in LMICs. Over 65% of these children were concentrated in just 10 countries, including Pakistan, which ranks third globally for unvaccinated and under-vaccinated children. In many households, mothers are primary caregivers, directly influencing childhood vaccination. However, in certain contexts, societal norms necessitate male approval from fathers or other male family members, which can delay or affect vaccine-related decision-making. In some settings, male children are prioritized over female children for healthcare, including vaccination, due to cultural and economic biases. The behavioral and social drivers of child vaccination, which are defined by WHO as the beliefs and experiences specific to vaccination that are potentially modifiable to increase vaccine uptake. They can act as barriers to vaccination in Pakistan. As Pakistan faces major challenges in routine childhood vaccination, it is imperative to explore the gendered behavioral and social drivers of childhood vaccination to develop effective and equitable vaccine interventions for enhanced vaccination uptake. Data source is the research project titled Understanding Structural Determinants of Zero-Dose Children in Urban Slums of Pakistan, which was carried out by the National Institute of Health Pakistan with the support of Sabin Vaccine Institute, USA. The sample population is mothers living in urban slum, and the total sample size is 1,392. Exposure variables are the behavioral and social drivers of child vaccination. First one is the mothers need permission from husband to take child for vaccination. Number two is mother's report of easiness to get child vaccinated. Third is perceived level of vaccine safety. The outcome variable is vaccine uptake for youngest child, and the data has been stratified by the youngest child gender. Here you can see the results. This slide shows a percentage vaccine uptake by the youngest child gender. You can see there is not much difference in the vaccine uptake among girl children and the boy children. Among the girls, it is 86.3%, while among boys, it is 86.1%. Percentage of the mothers who say they need permission to take their child for vaccination for boys is 71.2 children, and for girl child it is 69.3%. And percent of the mother who think it is moderately or very easy to get vaccination services is 80.1% for boy child and 83.4% for girl child. And percent of mothers who think vaccines are safe is 67.7% for boy child and 70.1% for girl child. On this slide, you can see the relationship of these behavioral and social drivers of vaccination to vaccination uptake. And mothers who say they don't need permission to take child for vaccination is significantly associated with vaccine uptake among the boy child. However, the perceived safety of child vaccine as well as the ease of getting child vaccination services is significantly associated with vaccine uptake for both boys and girls. Action steps. The findings indicate that parents they may be more hesitant to vaccinate their boy children than girl child, giving perceptions of vaccine safety which suggest a greater emphasis on safeguarding boys' health compared to girls. Culturally appropriate campaigns are needed to educate parents about the equal importance of boy and girl health, including safety and efficacy of routine vaccination. Healthcare workers should be trained to identify and address gender biases in caregiving, should they exist, and address specific concerns of parents related to vaccination. Integrated maternal, newborn, and child health services can encourage females to seek equal care for all their children, regardless of gender. Further analysis on social and behavioral drivers of childhood vaccination are needed, including focus on parents' education and number of living children. Thank you.
Great. Thank you so much, Dr. Nasser, for the presentation. And a reminder to everyone today, if you have any questions for our panelists, to please use the Q&A function to ask those questions. We will have a Q&A session following all the presentations today. I would now like to hand it over to our next speaker, Dr. Sunu Thomas. Dr. Thomas is an assistant professor in the Department of Public Health at the School of Medicine, Amrita Institute of Medical Sciences, Kerala, India. The title of her presentation is Childlessness and Intimate Partner Violence in India, Evidence from National Family Health Survey. So over to you, Dr. Thomas.
Hello, everyone. Good morning, good afternoon, good evening to everyone who has joined from different parts of the world. So as part of the Gender Equity, Gender-Based Violence Evidence Accelerator Fellowship, I have explored the association between childlessness and intimate partner violence in India using the National Family Health Survey data. My research question was whether childlessness is associated with intimate partner violence in India. So childlessness is defined as those currently married women who have been married for at least 5 years in the age group 20 to 49 years with seroparity. My outcome measure is the experience of physical, sexual, and or emotional IPV in the past 12 months. So why this topic is important, we know that IPV is a significant public health issue, and in India, 1 in 3 women experience IPV in their lifetime, with those residing in urban areas, those who are working, being Muslim, or those who belong to scheduled caste were at a higher risk for experiencing IPV. Also, evidence suggests that women facing fertility difficulties may also have a higher risk of IPV compared to those in the general population. We know that when there's infertility, women are often blamed for delays in conception, even though infertility could be caused by both male and female factors. And this blame can escalate to verbal, emotional, and physical abuse, putting women at a higher risk for intimate partner violence. We use this conceptual framework to understand childlessness and the association between childlessness and intimate partner violence among currently married women, considering various individual, couple, and family level factors. The data was the National Family Health Survey data, the 5th round. So my sample was women in the reproductive age group 20 to 49 years who were currently married and married for at least 5 years. So this total sample size was 52,391. And the main exposure variable was childlessness. The outcome was the past 12-month experience of any IPV, including physical, emotional, and or sexual IPV. The covariates include various socio-demographic factors as well as the tolerance of intimate partner violence. Now, among those total women, only 2.5% of the women were childless. This figure shows the prevalence of IPV in the past 12 months. So 27.4% of the women experienced any IPV in the past 12 months, with majority experiencing physical IPV, which was 23.6%, followed by emotional IPV and sexual IPV. This table shows the bivariate analysis between childlessness and IPV. So among those who had children, 27.5% had experienced IPV, and those without children, 22.8% had experienced IPV. This suggests IPV is slightly more common among those with children compared to those without, and this association was found to be statistically significant. Now, this table shows the bivariate and multivariate logistic regression. So the findings suggest that childless women were less likely to experience IPV compared to those with children. And the adjusted odds ratio is almost the same as that of an adjusted odds ratio, suggesting that the confounding factors did not substantially alter or change this relationship. Similar to any IPV, childless women had lower odds of experiencing intimate partner violence compared to those with children. Again, the adjustment for potential confounders does not significantly alter the results. What essentially these findings tell us that childless women are at a lower risk for IPV, both any IPV or physical IPV compared to women with children. Now, we also looked at the determinants of IPV among women with and without children and with children. So among those without children, alcohol use by husbands and belonging to scheduled caste increased the risk for IPV, and those with children having one or more co-wives, alcohol use by husband, currently working, and belonging to scheduled caste and tolerance of IPV increased their risk for intimate partner violence for women with children. So what this tells is that while we expected that childlessness to be a risk factor for IPV, we found decreased IPV among childless women as compared to women with children. And these associations were largely driven by physical IPV. And we know that women with children may be experiencing this because there may be barriers to leaving these abusive relationships because children are involved. And we also found that only 2 factors were associated with IPV among women without children, that is husband's alcohol use, as well as belonging to a scheduled caste. So the action steps that we would suggest is that the connection between fertility and IPV needs more attention in India. Healthcare providers, particularly obstetricians and gynecologists, should be sensitized about IPV and look for any signs of abuse during physical examinations for both women with and without children. Community health workers should be trained to identify signs of IPV, particularly physical IPV, early on in marriage for both those who have and have not had children. Now, has been that alcohol use was found as a significant risk factor for IPV among women. So we need to look at behavioral change programs and interventions directed at alcohol use among men, and including its linkage to counseling on alcohol use. Given preliminary evidence that drivers of IPV may differ between women with and without children, further research on risk factors and mechanisms for IPV among small subpopulation of childless women is needed. And duration of marriage or length of time trying to become pregnant could have an impact on women's experience of IPV, and further research in this area is also recommended. Thank you all, and any questions and comments are welcome. Thank you.
Great. Thank you so much, Dr. Thomas, for talking us through associations with IPV and parity with regards to children. We look forward to the questions in the Q&A. If you have any questions, please make sure to input those into the Q&A box. You should find that at the bottom of the screen. It will have lots of time at the end to be able to go over any questions. I'd like to now hand it over to our next speaker, Tein Wan, Tein Wan currently works as a women's voice and leadership advisor for CARE Myanmar. The title of her presentation is The Relationship Between Self-Reported Disability and Women's Experiences of Intimate Partner Violence in North Kivu, Democratic Republic of Congo. So over to you.
Good afternoon. I'm delighted to welcome you to my presentation on self-reported disability and intimate partner violence. As a global scholar of GHU Gender GBV Accelerator Fellowship Program, it's my privilege to share the key findings from this research. The research question focused on the relationship between self-reported disability and women's experience of recent IPV among women in North Kivu. As we are aware, the issue of disability and intimate partner violence remain a critical concern, particularly in the conflict-affected area. So, this research highlighted that disabilities-related social norms may put women and girls with disability at increased risk of IPV. Most existing GBV programs do not consider the intersection of disability and IPV, so it's GBV program do not consider specific needs and vulnerability of men and girls with disability. Despite their ongoing effort in this area, significant gaps still persist in our understanding and response. So this research seeks to bridge those gaps by providing evidence-based insight. Conceptual framework for this study emphasized on the relation between disability and IPV that is complex and interconnected. Here we control social demographic, gender norms, disability attitude, and conflict-related experience as a factor that could influence disability and IPV. Here is a brief outline of our methodology. We utilize cross-sectional baseline data from the ad-hoc program in North Kivu DRC that was collected by the International Rescue Committee in 2018. Our study focused on married women, 198 participants who involved in the ad-hoc program in North Kivu. Research main exposure is self-reported disability status that are categorized into 3 levels: no disability, mild, and moderate severe. The primary outcome was the experience of intimate partner violence in the past 3 months that was measured as primary variable. This study analysis includes several covariates that may influence the relationship between disability and IPV. As key findings, research revealed many main insights that I would like to share in this section. As you can see in this data chart, 79% of women in this study self-identify as having some form of disability. That is significant majority. The largest portion, 60.10%, indicated that they experience a mild disability, and 18.69% reported as having moderate to severe disability. Only 21.21% of women reported that they do not have any disability. IPV was high among respondents, with nearly 60% of women reporting at least one experience of IPV in the past 3 months. By IPV types, emotional IPV was the most common form of IPV. Slightly over 1/3 of women experienced sexual IPV in the past 3 months. Nearly 30% of women experienced physical IPV in their past 3 months. IPV privilege is high across all groups regardless of their disability status. Although statistically not significant, IPV was slightly higher among individuals with moderate or severe disability compared to those with mild and no disability status. For gender norms and attitude toward disability score are higher in the respondent groups who experience IPV than those who do not experience IPV. The difference is statistically significant in this study. This means that those who experience IPV tend to have more rigid or traditional gender norms and have more negative or discriminatory attitude toward disability compared to those who did not experience IPV. As main implication of these research findings, in this study, nearly 60% of respondents experienced IPV in the past 3 months, and IPV did not significantly differ by disability, but there was a significant difference in women's gender norms and disability attitude between those with and without IPV. As action step, with the high prevalence of IPV overall, we as humanitarian actors must ensure there are adequate GBV response services in North Kivu. Moreover, GBV service providers and practitioners need to consider the strategy to address harmful gender norms and disability attitude, which seems to play a main role in women's IPV experiences. Although in this study, IPV was similarly high for those with or without disability, GBV service providers should consider how IPV response is and the main causes of IPV, and that may differ by their disability status. More research are required to understand the main drivers of IPV in conflict setting, which include focusing on disability status and potential barriers to service providers. This final slide of this research presentation. Thank you for your time, and I would like to extend my sincere gratitude to each of you for joining us today, and I really look forward to hearing your questions and engaging in our question and answer section. Thank you.
Great, thank you very much for that very interesting presentation looking at the relationship of disability and type of disability with experience of IPV. And we have lots of great questions coming in. Please do input your questions into the Q&A function. We will have lots of time at the end to be able to go over them. So I am very delighted to hand it over to our final presenter today, Dr. Suresh Jugari, Dr. Jugari is an assistant professor in the Department of Public Health and Mortality Studies at the Center of Demography of Gender in the International Institute for Population Sciences in Mumbai, India. The title of his presentation today is Digital Empowering of Women and Intimate Partner Violence in India, Evidence from the National Family Health Survey. Over to you, Dr. Jugari.
So today I am going to present my research on digital empowerment of women and intimate partner violence in India, evidence from the National Family Health Survey. The project was completed under the guidance of Dr. Sunu Thomas. The research question: how does women's digital empowerment associated with experience of physical, sexual, and emotional intimate partner violence in the past 12 months in India? The justification why this topic has been chosen and why now. The prior research, prior literature over the last 2 decades has investigated prevalence of and underlying risk factors for IPV using successive rounds of National Family Health Survey NFHS data in India. These studies have investigated the correlation between women's empowerment and IPV, establishing that higher levels of women empowerment serves as a protective against IPV. Furthermore, research has indicated a nexus between women's exposure to mass media and a reduction in IPV experiences. However, limited studies have assessed the relationship between digital empowerment and experience of any form of IPV. Conceptual framework. This conceptual framework indicates how various factors are important in and relating to intimate partner violence at individual level factors like age of women, education, occupation, duration of marriage, husband's age, husband's education, whereas household factors like social status, type of family, number of children, caste she belongs to, place of residence, and wealth status of household. Whereas community factors, level factors, are community gender norms, patriarchy, community participation, and exposure to media. Whereas digital empowerment, women's digital empowerment factors like women's ownership of mobile, women's use of SMS use, internet access, and mobile phone use for financial transactions. Whereas which indicates which towards outcome is we consider as a intimate partner violence in the last 12 months, physical IPV, sexual IPV, and emotional IPV. Dataset, population, and measures. The study has used National Family Health Survey 5th data conducted in India during 2019-21. The samples included in this analysis were women aged 18 to 49, and the sample is 56,916, and weighted applied while analyzing the data. Main exposures were digital empowerment factors such as mobile phone use, yes or no, internet access, yes or no, short message services, SMS use, yes or no, mobile phones for financial transactions, yes or no. So socioeconomic covariate variables like age, place of residence, respondent education, number of living children, caste, respondent's father, be it her mother, women's working status, husband's education, husband's alcohol consumption, and region. And outcome variables considered were any violence, physical violence, sexual violence, and emotional IPV in last 12 months. Women's digital empowerment indicators, looking at this, 9.8% of women used mobile phones for financial transactions, 26.5% of women used internet access, and 48.5% of women had short message service use from mobile, and 56.8% of women had ownership of mobile phones. Past year sexual, physical, and emotional violence and any IPV. Any IPV in the 26.6% of women experience any IPV in last 12 months, whereas 4.9% of women experience sexual violence, and 11.8% is reported emotional violence, and 22.8% of women experience physical violence in last 12 months. Prevalence of any past year while IPV by digital empowerment status. This bar diagram indicating women having digital empowerment items and women who does not have digital empowerment items shows that women 24.5% women experienced any IPV, those who are having ownership of mobile phones, and 29.5% of women experienced any IPV, those who are not having ownership of mobile phones. 21.3% of women experienced those who had short message service use, and compared to 31.6% of women who do not have short message services. Whereas 18.5% of women experienced any IPV compared to 29.6% of women experience any IPV, those who are not having internet access. Similarly, 20.9% of women had experienced any IPV, those who are having mobile phones for financial transactions, and 20.7% of women experience any IPV, those who do not have digital mobile phones for financial transactions. So in 4 indicators, digital empowerment items are significantly associated with reduction into any IPV in last 12 months. Bivariate and multivariate logistic regression analysis shows that we have done unadjusted and adjusted analysis. Unadjusted for each atom run separately alone with violence outcomes, whereas adjusted ORs or models includes all variables in table together, like in addition to socio-demographic variables, inclusive of age, residence, respondent education, number of living children, caste, respondent's father with her mother, working status, husband's education, and husband alcohol consumption. The results shows that results highlight a complex relationship between women's digital empowerment and IPV. In bivariate analysis, as we seen, all 4 digital empowerment proxies negatively associated with IPV overall and physical, sexual, and emotional IPV separately. In adjusted analysis, owning a mobile phone and SMS use associated with the reduced sexual IPV, but did not associate with other forms of IPV or IPV overall. So in adjusted analysis, internet access associated with the reduced IPV for all forms of IPV and overall. In adjusted analysis, as the digital financial transactions were associated with increased overall IPV. So understanding the mechanism behind the relationship between digital empowerment and different type of violence is critical for future research, practice, and prevention. Action steps. Further research on mechanism between mobile phone financial transactions and sexual and emotional IPV specifically is needed. Measurement development surrounding digital empowerment, as well as exploration of ways to construct digital empowerment scales would be useful, with the caveat that the study finds variable relationship between different type of digital empowerment proxies and IPV. Investment in evidence-based programs to increase women's use of digital devices should concurrently seek to understand potential effect on violence risk. Policy-based efforts can simultaneously increase the awareness of women on using digital devices for empowerment and prevention of IPV. So these are the references used for study. Thank you.
Great, thank you very much, Dr. Jugari. So we've heard some really excellent presentations looking at the relationship between gender norms, roles, and relations, and vaccination uptake among children, as well as IPV. looking at it as relationship between whether women have children, the disability status, and also now digital empowerment. So I'm excited to move on to the Q&A portion. We have lots of great questions coming in. Not sure we'll be able to get to all of them, but I'm going to do my best to try to group presentations or questions together as they're coming in. So first, Omera, we're going to start off with you. There are a number of questions related to your presentation around new vaccine, thinking of a question around new vaccines being introduced or upcoming changes in the national immunization schedule in Pakistan, any future goals and priorities for improving immunization rates, and then also thinking about the role of fathers in immunization, and given their decision-making, the dominant role in decision-making, should immunization programs in Pakistan be specifically designed to target fathers? So I will let you address those questions.
Thank you so much, Rosemary. So regarding the first question about the introduction of new vaccines. So initially there were only 10 vaccines in the EPI, and now there are 13 vaccines by 2024. And in 2025, Pakistan has plan of introducing HPV vaccine into their vaccination program, and it will be in a phased manner. Initially, they will be targeting girls of 9 to 14 years, and in the second phase, all the girls of the 9 years, they will be included in this vaccination, and it will be part of the EPI soon. And the next question, it was related to any strategy that has been adopted to increase the vaccination uptake. So one of the strategy that has been piloted recently in Pakistan is the birth dose initiative, in which any child who is born in the hospital or any health facility, he will be vaccinated with BCG and will be given the first dose of polio there and then at the health facility. So that will be the first point of contact with the EPI people in the health facility, and they will be provided with the card, and they will be properly followed up by the health workers who of their own area. So there are different other initiatives that have been taken up by the government of Pakistan and EPI for improving the vaccine uptake, and one of them is that the campaigns that they have initiated campaigns in the communities, and they have involved their community members in the campaigns, and before the campaigns they do some advocacy, and they involve the head of the family, especially the males and the religious members of the society, who can advocate for the importance of vaccination in their community, and to the fathers and other senior members of the family who have the influence and have say in the family. So yes, the EPI Pakistan, they are working very hard to improve the overall vaccination uptake in Pakistan. Thank you.
Great, thank you, Omera. So Sunu, over to you. There are a number of questions for you regarding your presentations. A few of the participants today are surprised about your finding around those women who are childless having less IPV, and are expressing that a lot of other previous studies, especially in patriarchal societies like India, suggest that married women who do not bear children face higher IPV due to societal expectations of motherhood. And then even, being blamed, so another participant says being blamed for infertility sometimes increases IPV. Could you speak to this your finding, and why you think, does it differ from other studies? I'm just trying to look at other people's comments, make sure I've got all the right ones. And then a person also asked about possible outliers that might help explain this finding as well. So over to you.
Thank you for that question. Actually, I was also wondering why because I've read, empirical research, and I was thinking okay, this is higher among women with childless women compared to women with children, but we have to understand that this was based on National Family Health Survey data, and the specific questions that was asked to these women are, there are certain specific questions, and sometimes the women who are childless, who are experiencing IPV, may have a different form of experience of violence, as someone has pointed out, like blame and all those things which are not captured in the NFHS data. And that could be one reason why there is a lower, risk for IPV among women with childlessness, because there's a whole lot of emotional form of violence that could happen in the case of childlessness, and we need to have a more, elaborate conceptualization of how IPV get perpetrated in women without children. For instance, there would be threat of divorce, there will be blame of childlessness that is being disproportionately put on women. Then there would be also non-compliance with the treatment from the male partners. All these things can amount to, a kind of emotional abuse, which doesn't get captured in the NFHS data. That I think that is one reason why this data could not demonstrate that, and is different from other empirical studies. And also, somebody has asked, based on this, it is not common, then why we are talking about giving attention to this. Doesn't mean that it is not common, doesn't mean that the childless women are also not experiencing it. Our data shows that 22.8% of women without children are also experiencing IPV. So it is important that we give a due consideration to them also. And sorry, I forgot the other question.
No, I think you've addressed them. They were all related. Mm-hmm.
Then there was another question on caste. So I think caste, like those who are belonging to scheduled caste, there's different caste, scheduled caste, scheduled tribe, other backward caste in India. So if you're belonging to scheduled caste, then there's a higher chance of you experiencing IPV. So I think, these caste hierarchies could actually be reinforcing these gender norms in our culture. So I think that could be one reason why, if you're belonging to scheduled caste, or things that could be causing this higher risk for them. And in our sample, the proportion of women who belong to scheduled caste was 22.2%. So that was it. And yeah.
Great, thank you, Sunu. So
Yeah.
Tein, over to you for our next question. So Amina asks, did you isolate and characterize the various forms of disabilities to carry out the analysis to ascertain or link the IPV incidence to these disabilities, or the analyses were carried out across grouped categories of disabilities only? So Tein, if you can go on camera and unmute yourself.
Sorry, particularly which questions?
So the question is, did you isolate and characterize the various forms of disability to carry out the analysis to ascertain or link IPV incidence to these disabilities, or did you group disabilities together? So if you can go ahead and address that question, Tein.
Yes. Apologies. Because of internet connections and electricity cut down, I will not open video. And to answer the questions, these questions was collected as a survey with Washington group questionnaires with 6 domains, and it all was analyzed with 6 domains, and I also seen the questions that how we overcome the. I will check the question again.
Great, thank you. Okay, I think I'll can move on to that just to make sure we have enough questions able to get through these the rest of the questions. We have a few questions that are sort of larger that can be addressed to everyone, but I'm just going through some of the presentation specific questions at the moment, and then we'll get to those larger questions. And let's see here. So I think there's some good questions for you, Suresh, coming in around digital empowerment. One person asked, it was interesting to see how the different elements of digital empowerment have different effects on the types of IPV. What are your reflections on how women are using these digital devices? Are they being used as income generating tools or as sources of information that change and shape attitudes towards IPV?
Okay, thank you. Thank you for questions. And at the outset, I would like to thank you all participants for their active participation. So this, the National Family Health Survey, which is a demographic health survey in India, is asked questions on women mobile use, and also asked a question on mobile use for SMS use and mobile use for financial transactions. So this financial use of financial transition is not for just business purpose, but it is overall the question asked for everyone. So it may be the internet banking, it may be mobile banking. So the question asked to everyone. It's not specifically to the people those who are for income generation. So it is in a general question. So that is one thing. And yes, we too are very see that there is a different kind of what we say associations are reflecting for our study, and this indicates that the importance of understanding digital empowerment of women is very important in multifaceted ways, because there is a tremendous increase in digital devices and use of digital devices has increased for several reasons. So I think that's what my comments. Thank you.
Thank you, Suresh. So there is a question related to particularly the 3 studies that focused on intimate partner violence. So asking around social desirability. So studying IPV is a very sensitive and confidential topic in many cultures. And how did you overcome the social desirability issue? So this is related to either Suresh, Sunu, and Tein. If one of you would like to come in, and then if anyone else can come in, please do.
So this, as far as this Sunu's and my study is coming from National Family Health Survey data. So National Family Health Survey data have a very standard and validated questionnaire, which asks questions on set of questions to women on important various aspects of violence, intimate partner violence. And the survey follows a rigorous protocols which allows to have like privacy. The women have a privacy, and they ensure that the interviews are conducted in privacy and ensure that this following all protocols. Therefore, and this is also part of our demographic health survey questionnaire, so that in that way this survey captures I mean there is very less or many less bias about our social desirability. So that is what from my side. But yes, as this is a very sensitive topic, there is a possibility of any minor, social desirability. But this is a well accepted, questionnaire which used to capture this prevalence. Thank you.
Great, thank you, Suresh. Sunu or Tein, would either of you like to come in to address that question around social desirability issues regarding studying IPV?
Yeah, I think Suresh has explained it because it's based on the National Family Health Survey data, and there's a specific methodology and things how it has to be asked, and the questions are kind of validated questions. So I think definitely there would be a desirability bias that would keep in, but that is kind of taken care of with the kind of structured questions that is being asked.
Great, thank you, Sunu. And Tay, did you want to come in?
Yes, for our survey questions, ethical approval was obtained prior to the research by from the International Rescue Committee institutional review, and also other survey questions. All the survey questions procedures are followed by the GBV guideline, especially research areas. Thank you.
Great, thank you very much. There's a question in the chat from Mohammed Rafi, who asked around how do we address, or you're thinking around how we address resistance from particularly male community leaders when advocating for gender equity. So this is, I'm putting this to any of our 4 presenters. So if one of you would like to address this, please do come in. And as no one's coming in, Omera, I'm going to hand this question over to you. So what do you think about addressing resistance from male community leaders when advocating for gender equity?
Yeah, thank you so much, Rosemary, for your question. So as we have been working in the communities, and even my research that was related to vaccine uptake, it also has that component in which we faced resistance from male community members. So what we adopted was that it depends upon the type of communities and their norms and the culture. So you need to have culturally sensitive approaches are needed to address this issue. For example, in Pakistan, we have different ethnicities residing in different areas, and for each ethnicity, there are different ways in which we address this. For example, in one of the urban slums where there were more Pashtun were residing, what we did that we involved their religious leaders and their tribal heads, and we made a group of them, and there was and one of the senior member was leading that group, and we used to go to the leader, and we used to tell them about the importance of the vaccine, and we used to address all their concerns related to the vaccination side effects, because they had different myths related to it, that like some used to say that it is a foreign agenda, and they said that their children, they get ill when they get vaccination, they get fever and they get ill. And so what we did, we went to those leaders, and we addressed all the concerns, and we satisfied them, and we took with us other healthcare staff as well, who are working in their area. And so that was one move that has helped us in improving the vaccination uptake and addressing the resistance that was coming from the male members. So I'm sure my colleagues who have been working in gender-based violence and GBV, they must have used some very culturally appropriate methodology to address this issue, because every culture and every ethnicity, they have their different norms and different setups, and we need to address these issues accordingly. Thank you.
Great, thank you for that response. I think we have time for one more person to come in if they'd like to address this question.
Maybe
Sunu, please go ahead.
Yeah, maybe we could use participatory approaches by involving men in the, in making these changes. Also, I think to involve more younger generations or younger male leaders, so we can have a long-term cultural shifts in their notions around gender equity and equality. So that is one point that I would like to add.
Great. I think Suresh wants to come in. Please do.
Yeah, as we know that the latest evidence shows that the intervention to amend the masculinity behavior works in early ages than later ages. So the interventions to target changing behavior or inculcating gender equitable behavior in the early ages would be a much relevant intervention. I would say, and that literature around the world indicating us that early intervention would be our best intervention that can, so thank you for.
Great. Thank you. I think that is all the time that we have for questions, and we weren't able to get to all the questions. We had lots of really good ones in the chat, in the Q&A. So thank you everybody who submitted their questions, and apologize if we haven't been able to address your question today during the webinar. I'd like to hand it back to Dr. Michelle Decker to close us out.
Wonderful. Thank you so much. I think we've had such an incredible tour through different types of gender analyses, gender differences regarding the childhood vaccinations, IPV and the links with childlessness, with disabilities, and even looking into sort of mobile and digital empowerment. And I just want to give a huge thanks to each of our presenters, Dr. Omera, Dr. Sunu, Tein, Dr. Suresh, just incredible work today. And through the fellowship. And for those of you online, I think this really gives you an opportunity to get a taste of the work of our evidence accelerators and as well the center here at Johns Hopkins. And I just want to give a final thanks to all of our supporters, Dr. Morgan for being a fantastic moderator, to our IT team, Salam, all of the work that went into pulling this together for today. I encourage all of our listeners as well to join up for the, we've got 2 more webinars in this series. One is a little bit later today, and the next one is tomorrow. I'm not going to name the time zones because you're on all different time zones, and invite you as well to follow us on LinkedIn and through our center page, which Dr. Morgan has posted. And we really look forward to the next steps in this journey. I think our Q&A have given us some opportunities to be thinking what's next in intervention and prevention, especially bringing in these gender norms. So thank you again. And with that, we'll close our session for today. Thanks to all.